Good morning, all of you. Thank you, conference committee, for giving me this opportunity. I would like to give my thanks to the Lupin team. And so I will be discussing about treatment optimization in type 2 diabetes with cardiorenal metabolic approach. Slides are not moving. Would you just check? With this, okay. Okay, great. So current situation of type 2 diabetes in India is alarming. We are the second most prevalent country after China, and ICMR has conducted this study to look for prevalence of type 2 diabetes and how many percentages of patients are achieving their target A1C and other parameters. As we can see in the graph, only 20 to 30% patients are achieving their A1C goal. Around 70% of patients are not achieving their A1C goal despite of availability of wonderful molecules. Same is true for the other parameters like blood pressure, the LDL cholesterol. We all know diabetes is the major risk factor for cardiovascular disease, and we have increased risk of developing diabetic kidney disease. So when we compare Asian patient with the Western population, then Asian patient has more prevalence of diabetic kidney disease than the Western population. And in Western population, they have higher height, so there is increased length of nerve fiber, and they have higher prevalence of polyneuropathy and diabetic foot complications. So we need to address these two important factors in our patients of diabetes. So what are the current guideline recommends? So most of the guidelines after lifestyle modification, if patient has ASCVD, then we can start with the either SGLT2 or GLP-1 agonist. If patient has heart failure, then the first line would be SGLT2 inhibitor. Or if patient has diabetic kidney disease, then the first line would be SGLT2, and also GLP-1 have some favorable effect in patients with diabetic kidney disease. If the hypoglycemia is the concern, then we can give insulin sensitizer except for sulfonylurea. If the weight is the concern, then the GLP-1 agonist is the drug of choice. But diabetes management should be individualized and treatment should be reviewed every 3 to 6 monthly to prevent the therapeutic inertia. Initially, the approach was the glucocentric, but nowadays the diabetes management is the holistic approach. It is the comprehensive management. Apart from glycemic control, we need to address blood pressure management, we need to look for lipid management, and we need to give certain molecules who has favorable cardiovascular outcome. So when we talk about Asian Indian phenotype, so what is the Asian Indian phenotype? So we have high visceral fat, low muscle mass, less number of beta cells. We have higher rate of apoptosis of beta cells. We consume more carbohydrate. With the same amount of carbohydrate, we have high postprandial glucose excursion. Altogether, this increases the risk of type 2 diabetes in our Asian patient. So are we providing the optimal treatment to our patients in regards to cardiorenal abnormality? Then To provide comprehensive management, we need multi-specialists. So primary care physician can bridge the other specialist doctor. And when we talk about the SGLT2 inhibitor, then it has favorable mechanisms like it excretes 80 gram of glucose through the urine, which means it excretes 300 kilocalorie per day, and thus it reduces the 2 to 3 kg of weight loss. It has favorable outcome on the cardiac myocyte. It increases the ketone body for the utilization. It reduces the oxidative stress. It reduces the LV thickness. Apart from this, it has some pleiotropic effect, like it reduces the systolic blood pressure by 3 to 4 mmHg and by diastolic pressure by 1 mmHg. So what about the combination of SGLT2 and DPP4? For any combination, it should be rational, it should be synergetic, it should have better glycemic efficacy, and it should be safe and tolerability should be there. So when we see the mechanisms of dapagliflozin and linagliptin, DAPA leads to glucosuria, which reduces the glucotoxicity. In turn, it improves the beta cell sensitivity. However, it increases glucagon level. When we talk about DPP4, it increases the GLP-1 level, and along with this, it also suppresses the glucagon and opposing the action of dapagliflozin. DAPA can be used in the wide variety of type 2 diabetic patients, like type 2 diabetes with obesity or atrial fibrillation or with heart failure, or any patient who has diabetic kidney disease. Even in non-diabetic patients who has heart failure, then the DAPA has the favorable outcome. The beauty of linagliptin is there is no dose adjustment is needed in patients with renal and hepatic impairment, because linagliptin is excreted via the bile, and before starting this molecule, we don't need serum creatinine. So I mean, this is the only gliptins who has this kind of effect. When we compare linagliptin with the other gliptins, then all gliptins can be given as a mono, dual or triple therapy. But when we talk about CV risk, heart failure and the renal safe molecule, then linagliptin is definitely superior molecule. So what about the current evidences for the dapagliflozin and linagliptin? The famous randomized control trial, which was the CVOT trial for the dapagliflozin, which has studied the type 2 diabetes patient with the underlying cardiovascular disease. As we can see, there was 16% reduction in mass, and the greatest reduction was seen with the recent cardiovascular event within 2 years. DAPA is also has favorable outcome in patients with heart failure and also for diabetic kidney disease. Sorry, slides are not working. After these slides are not working. Anyway, it's okay. Anyway, let me present in this way. So when we compare dapagliflozin in heart failure patients, then heart failure can be with the reduced ejection fraction or with the preserved ejection fraction. Dapagliflozin would be more beneficial in patients with reduced ejection fraction. It was associated with the 48% reduction in the relative risk with the reduced ejection fraction. When we compare the dapagliflozin and the linagliptin combination with the linagliptin monotherapy, then combination is definitely superior. This was the randomized control trial in which the combination group has a higher proportion of responder, and there was significant weight reduction with the combination. So this single pill with the DAPA and Lina are hitting the 5 pathogenesis out of 8 pathogenesis of ominous octet. It has higher glycemic efficacy, it has pleiotropic effect, and the combination is safe and the tolerability is also good. When we compare the DAPA and linagliptin, then this combination is the ideal alliance like India and Russia, as the SGLT2 inhibitor decreases the insulin secretion, it increases the glucagon secretion, and it increases the hepatic glucose output. While DPP4 increases insulin secretion, it decreases or normalizes the glucagon secretion in presence of SGLT2 inhibitor, and it reduces the hepatic glucose output. So, in this combination of DAPA and Lina in a single pill has higher glycemic efficacy with some pleiotropic effect and better tolerability, and both the molecules are comprehensively studied. So let me summarize that type 2 diabetes is associated with the micro and macrovascular complication. We need to shift from glucocentric approach to patient-centric approach. The combination of DAPA and Lina has higher efficacy, and the once daily regimen makes it well compliant molecule, and it improves the quality of life. With this, I end here. Thank you for patient listening.